Hello, and welcome to this Practicing Clinicians Exchange podcast. I'm your host, Nicole Mitchell. This is the second of a 4-part podcast series based on the webinar, Improving HIV Prevention in Primary Care, the Evolution of PrEP. In today's episode, listen as Dr. Latesha Elopre, Associate Professor in the Division of Infectious Diseases at the University of Alabama at Birmingham, discusses the new CDC PrEP guideline recommendations. For more information on Dr. Elopre and all our faculty, along with downloadable slide sets, quarterly clinical thought commentaries, and a point-of-care resource hub, please visit pce.is/PrEP. Now, let's get started and hear what Dr. Elopre has to say regarding the new PrEP guideline recommendation.
So after you've moved from the step of, I've engaged and talked to my patient, I understand their sexual history, their sexual health, and their sexual goals, what about engaging them when it comes to PrEP care? So we're going to talk first about the new PrEP guidelines and the recommendations that they have. So the updated recommendations by the Centers for Disease Control and Prevention, number one, say that we should talk to everybody who's sexually active about PrEP. Everyone should be educated about PrEP. And what can make it easier is if you already have information in your clinic, posters on your wall in your clinic, that prompts that conversation. But if someone reports in your sexual history that you take, that they are sexually active, you should educate them that there is a prevention tool called PrEP that could be available to them. And I think that the goal why so many people were excited about this change is because this decreases the stigma that can be associated with starting the conversation about PrEP. When we were initially talking about this, we talked about groups that were at risk. And people knew that. People knew that in the commercials, there were only certain populations being featured. And that can unintentionally and did stigmatize those groups. So by opening up and saying this is something that is available and appropriate for anyone who's sexually active, I think it makes it a lot easier to approach this conversation with your patient. The CDC also provides some decision trees for you. So again, once you've taken your sexual history and really based off of site of exposure, walking you down this algorithm, this tree. I will point out that if you look at the CDC guidelines and this decision tree that they've provided, they still have the question, do you have sex with men, women, or both? This is somewhat outdated. Now we ask people, what is the gender of the person that you have sex with? So for anal or vaginal exposure in the past 6 months, you can see in the decision tree if they report yes. If they have a partner who's living with HIV, it's important to know if they are undetectable. Because as I said, if you're undetectable, you can't transmit. But if they're not, then you might recommend PrEP. And you'll see that it also says discuss PrEP and prescribe if requested. So we never deny PrEP to anybody who's interested in being on PrEP. Same thing, walking down the decision tree if they report that they've had sex with more than one person and they do not know their HIV status. Then if they're not using condoms consistently, PrEP may be appropriate or something you should recommend for that client. And then the same as you see for past 6 months. If you have anal exposure as your primary route of potential risk for getting diagnosed with HIV, we look at specifically gonorrhea, chlamydia, and syphilis. But for people with vaginal exposure, it's gonorrhea and syphilis as the major predictors and the things that we look at in regards to STIs in the past 6 months that make you at more or higher risk of being diagnosed with HIV. We also have clear guidelines for people who inject drugs. There's really one clinical trial that supports this. And for this specifically, you can see that if you've reported that you've injected drugs in the past 6 months and you've shared equipment, then likely PrEP would be beneficial for you. And I saw in the chat, I'll go ahead and answer it. When it comes to age, it's based off actual weight, 35 kilograms. So you can prescribe PrEP for adolescent populations, which is fantastic. So that's why I mentioned earlier when we're talking about sexual history taking, that first question may be just about who you like, who are you attracted to? Have you started thinking about this? Because if you start broaching that conversation with an adolescent and you find out that they are sexually active, PrEP could be an option for them. So we're going to just jump right into the updated recommendations in regards to our newest isn't a word, but our new PrEP modality, which is our long-acting injectable cabotegravir. So again, a lot of people are very excited about this because we know that, and we'll review later, modalities are different in regards to options available based off of site of exposure. For vaginal, versus anal exposure. But cabotegravir has been studied in all populations and is available for all populations at this point. So in adults who are sexually active, healthcare providers can prescribe cabotegravir injections as PrEP. And this was recently approved in 2021. So right now, the biggest shift and the reason why a lot of people are talking about this is because you receive the injection every 2 months instead of the 3-month interval that you have for oral PrEP. And there's contraindications due to chronic kidney disease that prevents other PrEP use that you don't really find with cabotegravir. So people are really excited. The biggest shift, though, is that we are now doing viral loads, and we are doing this because of data that really came out related to the cabotegravir trials. So when you're starting or restarting PrEP, you always want to do the HIV antigen antibody laboratory-based test now based off of new guidelines and what they recommend. And then you want to do that RNA test. And of course, if either one of these come back positive, you would want to have a plan on how you can link someone to HIV treatment. If it's negative, then you can prescribe PrEP. And the reason why they are now asking for us to check viral loads, which are only lab-based, there are no point of care rapid tests for this, is because in the cabotegravir trials, they did have people who, while having detectable levels in their blood that were appropriate, saying that they were adherent to cabotegravir, still acquire HIV. And the viral load allows us to detect acute infection. So really, I'm going to take you down this decision tree. If the patient has not taken oral PrEP or PEP in the past 3 months and has not received long-acting cabotegravir injections in the past 12 months, and they report that they want to start PrEP, they don't have any signs and symptoms that are consistent with acute infection, then you would send off this plasma HIV antigen antibody assay, and you can see that if it's positive versus negative. If it's positive, again, you would want to link them to HIV treatment and care. And if the RNA came back detectable, and for us, detectable means that for most standardized assays, you have a viral load that's greater than 200. And we would say that that person is acutely infected and they are living with HIV and they need to be connected to care. And this is something that, again, you'll be tracking with cabotegravir and now recommended through CDC with all of our PrEP options at RNA level.
Thank you very much, Dr. Elopre, and thank you to the listeners for joining us. Up next is the third podcast. Dr. Elopre is going to discuss non-pharmacologic prevention of HIV, as well as pharmacologic PrEP options. As a reminder, to view the full program and to join the discussion, please visit the PCE website, pce.is/PrEP. As always, thank you for listening.